let's jump into the biopsy conference.
All right, thank you. So Goyon will present the clinical case. Just in full disclosure, this is a very complex case with a biopsy and unfortunately an autopsy as well to interpret. And it was discussed in professors' rounds as well, but hopefully we can have a slightly different discussion from the pathology point of view today. So I'll hand it over to Goyon to present the clinical portion here.
Hello, everyone. This is a very complicated case, so I'm going to read through my slides very quickly so we have enough time to talk about the pathology. So 18-year-old female presented with sudden onset generalized swelling, shortness of breath, altered mental status, a neuric AKI after steroid treatment for weeks of urticaria. In November last year, patient had on and off urticaria and weakness. During Christmas, patient went to the emergency room, was given sodium medrol dose pack and loratadine. Symptoms improved initially, but then got worse, accompanied by weakness, general edema, shortness of breath, abdominal pain, and diarrhea. On January 10th, patient went to urgent care, was given dexamethasone 10 milligram. Then she developed altered mental status, blurred vision, gait imbalance. Patient was admitted to outside hospital. Patient doesn't have any significant past medical history except seasonal urticaria when she was in Vietnam. Patient doesn't have recent sick contact. Last time she was in Vietnam was 1 year ago. Patient was not on any medications, no significant family medical history. On arrival, patient's blood pressure was 140s to 160s, over 80s to 90s, heart rate 100. Patient was afebrile. Creatinine 5, potassium 5.4, sodium 133. Liver function was normal, hemoglobin 12.3, white blood cell count 28, platelet 43, MCV 81, frequent schistocytes on blood smear, LDH more than 2400, eosinophils 5.9. CRP 3.3 ESR normal, HCG negative, lactate 2.1, EKG and troponin normal. No urine studies. PAN-CT showed pancreatitis, small bilateral pleural effusions. Patient was intubated due to altered mental status. The disease was rapidly progressing. The next day, creatinine increased to 5.9. Hemoglobin dropped to 11, platelet dropped to 22. Hemolysis workup positive, DAT test negative. Ruled out DIC G6PD deficiency. ADAM TS 13 was sent, plasmic score 6. So patient got plaques on January 12th. APLS, ANCA, GBM, ANA all negative. C3 low, 71, C4 almost like nothing, C4 less than 8. White blood cell count 27, eosinophils increased to 11.6. Patient had flow cytometry, which showed eosinophilia, no abnormal B or T cell population. Tryptase normal, serum vitamin B12, low normal. IgE level was elevated. Infection workup all negative. They also sent strong gynoides, IgG. Which was pending, but because patient had altered mental status after steroid treatment, so they started ivermectin. Next, yeah. So given this anuric AKI in the setting of TMA, hypereosinophilia, altered mental status, and possible infection, our differential diagnosis included TTP, HUS, other infection-caused TMA, and hypereosinophilia. HES, and we were thinking maybe these two causes are two different diseases at the same time, hypereosinophilic syndrome and complement-mediated TMA. But there are case reports also reported HES can cause TMA, and we were also thinking this may be CM-TMA triggered by EGPA. Next. Patient arrived at Mount Lake on January 13. When she arrived, there was no rash. She had anasaka. She was intubated. Blood pressure was still stable, 130s over 50s. Not on process. Afebrile. Creatinine 6.2, hemoglobin 11.5, platelet 23. Eosinophils. After treatment, decreased to 6. LDH decreased to 1,000. Patient had normal liver function and coagulation panel. X-ray showed new aspiration pneumonia. MRI brain showed possible meningitis and or vasculopathy. Next. We did further infection workup, which were all negative, and further workup for the hypereosinophilia were also negative, especially the serum tryptase was normal. We did autoimmune and complement workup, all negative except the persistent low C3 and low C4. CH50 was low normal, 47.1. We also requested complement functional panel and the gene test, but unfortunately, they didn't send the gene test at the end, only send the functional panel. According to the genetic consultant, we also sent mitochondrial DNA and the nuclear genes test. Next. The primary team also did CT sinus and sinus biopsy, which didn't show vasculitis or eosinophilic infiltration. They consulted ophthalmology for vision change. It also didn't support vasculitis. Next. The ADAM TS13 activity came back was negative, so we discontinued the plaques after 2 days. And the ivermectin was discontinued as well because strong geniolitis was ruled out. Patient got solumaglor house dose on the first day when she came here. She got 1 gram per day for 3 days, followed by prednisone 60 milligram per day. And we also started hemodialysis for clearance because patient was persistently anuric. We started eculizumab on January 15 because of concern about complement-mediated TMA. They also started empirical antibiotic treatment. Next.
Okay. So this is around the time that the kidney biopsy was done. And so the question was, what is going on in there? There was this presentation with hypereosinophilia, kind of a microangiopathic hemolytic anemia picture as well. We'll talk briefly at the end about hypereosinophilic syndrome and the various causes. But so far, many of the workup for that known causes of hypereosinophilic syndrome were kind of negative, including kind of malignant workup as well, and malignant triggers of hypereosinophilic syndrome. So let's take a look at the kidney biopsy, and then maybe we can figure out what was going on. So the biopsy, we had a good core, and you can see at low power there were lots of glomeruli, not a lot of chronic injury, but a lot of pink. And we'll take a look at these components individually. The main things to take away at low power is that there's not a lot of chronic injury. There's not a lot of inflammation either. So looking at higher power, we can start to see that some of these tubules look a little bit unhappy. The glomeruli also are unhappy as well. We'll get to those in a second. But the tubules really were quite striking. There was a severe acute tubular injury. We don't usually see, necrosis in the kidney, but we were essentially seeing that here. So here are, completely dead cells, epithelial cells that are shed into the lumen. You can't even see their nuclei over here. So there's nothing lining these tubular based membranes. Here you can see some apoptotic cells with kind of these pycnotic nuclei that are also shed into the lumen. So there was severe acute tubular injury, acute tubular necrosis, correlating with the poor serum creatinine. Some tubules also had vacuolization. That's another form of acute tubular injury. Let's move to the glomeruli. So the glomeruli diffusely look very kind of ischemic. They're kind of shriveled up. This is a kind of an acute ischemic appearance because there wasn't much chronicity in terms of that reaction and fibrosis we see around Bowman's capsule. And in addition to that, we were starting to see that the endothelial cells lining the capillary loops were frequently swollen, and there's potentially fibrin thrombi within them as well. So this is kind of a generalized picture. Pretty much all the glomeruli showed some variation of this. So here's a fibrin thrombus, some blood. There's some congestion in here, probably another fibrin thrombus. Very ischemic looking picture. Normally when in a glomerulus, you should see patent capillary loops and a lot of white space. And we're not really seeing that here. Of note, there are some leukocytes that are coming in here. These look mostly mononuclear in appearance. So just keep an eye on that in the subsequent pictures as well. So this is an H&E stain, and it showed another kind of key finding here. So you can see that this entire glomerulus seems kind of like swollen shut. Again, we're not seeing white spaces. We're seeing some, it's hard to tell what exactly these nuclei are. Some of them might be infiltrating leukocytes. Here's a neutrophil over here, but most of the others are kind of mononuclear cells, maybe monocytes or lymphocytes, and swollen endothelial cells. But the key thing I want you to take away are all these little red bits, fragments, which are actually fragmented red blood cells. So we have endothelial injury. We also have evidence of a hemolytic anemia, microangiopathic hemolytic anemia, that correlates with the schistocytes that were seen pretty much throughout the entire patient's hospital course. So here's another view of that. Again, you can see these are fragmented red blood cells, really swollen endothelial cells, and the capillary loops are kind of just completely closed up in here as well. So there's fragmentation of RBCs that we can see within the kidney biopsies. Again, negative here is we're not seeing eosinophils, which was a kind of a clinical question at the time. We're not seeing any kind of crescentic glomerulonephritis, thinking about an eosinophilic GPA either. So the immunofluorescence was essentially negative, other than these fibrin thrombi, which we could see within the glomeruli. The EM confirmed that there was endothelial cell injury. Here's a plug of platelets within the capillary loop. There was some degree of effacement as well. Some of the endothelial spaces subendothelial spaces had a little bit of electron dense material here. There weren't really immune deposits by IF, so we didn't think this was an immune complex driven process, and it was kind of variable in its appearance. We did see evidence of endothelial injury. So here I'll call your attention to this capillary loop. I'm outlining the basement membrane over here. Where is the lumen? The lumen is actually kind of over here. And so this endothelial cell is quite swollen. You don't see its normal fenestrae. There's all this expansion of the subendothelial space. This looks kind of subacute because some cells have stuck their processes in there. There's some electron dense material in there. And also this is a fragment of a red blood cell that is now trapped beneath the endothelial cell layer. So we're seeing the ultrastructural correlate of what we saw by H&E, which was that fragmentation of red blood cells and endothelial cell injury as well. So the final diagnosis was acute thrombotic microangiopathy. We were not seeing any inflammatory cell influx that has been reported with hypereosinophilic syndrome with direct involvement of target organs. There was quite widespread acute tubular injury as well, but not a lot of chronic injury. So of course, TMA has this wide differential diagnosis, which was already being evaluated, and some of these causes were probably ruled out. Complement-mediated TMA, again, was perhaps incompletely evaluated just by the quirk of what happened in terms of it looked like soluble factors were probably ruled out, but genetic factors, we still were kind of in the dark about that. But some of these other causes were probably ruled out as well. So what exactly was going on? So Gayan will tell us a little follow-up, and then I'll discuss the autopsy findings. Gayan, are you there? Oh, you're muted, I think.
Sorry.
you're on.
Yeah.
Oh.
Okay, there you are. Thank you.
Yeah, the follow-up is like patients develop shock secondary to gram-negative aspiration pneumonia. Her status improved shortly after they broadened antibiotics, but unfortunately, patients got like extubated, then reintubated in a couple hours, coded multiple times. ICU did everything, but unfortunately, we couldn't save her life. She passed away.
Okay. So So we're kind of left with a little bit of a mystery. It sounds like, the last couple of days, and I'll show you a graph about this as well. Clearly, there was kind of more of a DIC picture that was developing, which was not quite there in the earlier at the time of admission and the earlier hospital course. But it did look like there was kind of a TMA-like process that was going on throughout the entire time, which couldn't explain the multiple organ involvement. So let's take a look at some of the findings from the autopsy. And so this was a section of her lungs. And so these were really congested. They were very heavy. So the normal lung should be around 300, 350 for the right and left lung. These were almost double that weight. They were also, rather than being kind of pink gray in color and spongy in appearance, they were very solid looking and very red. You can see here, this is the pleura that's glistening on the outside. So these were congested with blood. And in some areas, you could see perhaps like fresh blood clots as well that were stuck in the vasculature. And this was kind of a diffuse finding that there were thrombi pretty much everywhere within the lung vasculature, which might have been the more proximal cause of death. So looking at the lungs, here is a relatively preserved or intact part of the lung. Now, there was a kind of a long postmortem interval of a week. So, the tissue quality was degraded as a result of that. But he was a relatively normal looking lung that you might expect to see. But the majority of this patient's lungs look like this. And so here we have some blood and air spaces here, but pretty much all the alveoli are filled with edema fluid and blood as well. So this corresponds to that heavy weights at initial gross examination and that red, almost liver-like appearance because of all the blood and edema fluid that had accumulated. So this accounts for that respiratory failure that she had. There were also what looked like kind of fresh blood clots. There wasn't really, any kind of reorganization or lines of fibrin deposition where we think of preformed thrombi that have then embolized to the lung. So these look like there were fresh clots that were kind of stuck in many of these blood vessels within the lung. Now I'm shifting gears to a different organ here. This is a section of pancreas, which is somewhat preserved, amazingly enough, after a week post-mortem. And it's very pink, but what you're seeing here are little clusters of cells. These are the pancreatic acini, the secretory components of the pancreas. So this is a portion that was relatively intact. Here in a lower power view is an area that is undergoing necrotizing inflammation here. So here again are kind of the more preserved portions of the pancreas. Right in the center here, you can see that it's much more cellular. You can see a lot more dots. And if we go at a higher power, we can see that there are inflammatory cells, including a lot of neutrophils and a lot of debris from the necrotic cells. So this is likely a pre-mortem finding that there was inflammation and necrosis of the pancreas. This corresponds to the imaging finding of pancreatitis as well. Though there's maybe an apparent discrepancy because the lipase level, which was only checked a day or two before her death, was only mildly elevated at, I think, about 119. So just about double the upper limit of normal. So let's look at the bone marrow. So interestingly, with this diagnosis or presumed diagnosis of hypereosinophilic syndrome, the bone marrow, I don't think was actually evaluated during her course. All the flow cytometry and evaluation was done on the peripheral blood. So here's kind of a section of her bone marrow from the rib, I believe. So here are some bone spicules. And here you could see the major three lineages are forming. So here's a megakaryocyte forming platelets. You can see some of these darker red round nuclei here are forming red blood cell components. Some of these larger cells in this area are probably blasts and developing myeloid cells as well. But what was striking to me is that at higher power, as I'm looking at this slide, there were a lot of cells that had kind of more eosinophil-like granules, like here, here as well. So this was a little hard to see in this postmortem specimen. I'm trying to get actually a Congo red stain, which can highlight some of these eosinophil granules to see if there were increased numbers of eosinophils and eosinophil precursors in the marrow, which would correspond to the peripheral hypereosinophilia the patient had as well. So what can we kind of take away from this, very sad and kind of dramatic case? So, I mean, I think the patient probably met criteria for hypereosinophilic syndrome. Her absolute eosinophil count was clearly above this level of, greater than 15,000 per microliter, definitely prior to a transfer to UW-MC and for the majority of the time that she was admitted. It's interesting that the steroid treatment, both in the outside hospital and at UW, seemed to suppress the peripheral eosinophilia, but we had no idea what was going on in the bone marrow. And so we'll talk about that a little bit as well. So this is kind of the criteria. She met the criteria for numbers, never really evaluated the bone marrow. And so we'll see that in the pending Congo red stain. This was kind of the missing link for us, right? The only tissue that we could see, at least I saw, was the renal biopsy, and there really weren't any eosinophils in that tissue. But there was evidence of multi-organ damage. The question was, is this due to the TMA, or is this due to direct eosinophil infiltration and damage of the organ? Now, these are very hard syndromes to pin down. The main things are any of the known triggers for these hypereosinophilic states, such as myeloproliferative and lymphocytic neoplasms. These seem to have been ruled out, at least based on the peripheral blood. We don't know about that in the bone marrow as the source for these neoplasms. And then the rest are very unsatisfying in terms of thinking about triggers. So sure, infection like strong G, which was ruled out, can trigger HES. Inflammatory disorders such as like a eosinophilic GPA may be associated with a hypereosinophilic syndrome. And then there are these very unsatisfying categories of saying, well, there's a family history and there's idiopathic causes of HES, which may be where this patient is best categorized. Now, there have been several reports looking at if a renal biopsy is actually done in the context of HES, what kind of pathology might you see? And as you can see, there's a whole bunch of different things that you could see, So it's very hard to say that a particular form of renal injury is directly caused by HES. However, several reports have mentioned thrombi, thromboembolisms, infarcts, and maybe even TMA. And so the question is, can HES cause TMA in the allograft, or is it due to, in the kidney, or is it due to direct eosinophilic interstitial nephritis, perhaps, in the kidney? So a few cases have been reported with renal TMA. And so in all of these cases, of course, there was, hypereosinophilia. They evaluated the bone marrow, and this was frequently markedly elevated amounts of eosinophils there. But interestingly, all the cases that have been reported so far have also described an eosinophilic infiltrate into the kidney, which we did not see in this case. So what they have shown in previous cases, for example, and these are terrible pictures, but this is the original quality, that there was a very congested glomeruli. Some of them had thrombi, and there were actual eosinophils, which are these even darker red granular appearing cells infiltrating into the glomerulus and in the interstitium as well. In EM, they were able to see what they reported as eosinophilic granules, degranulated eosinophil remnants in the affected glomeruli. And they even showed immunofluorescence for the major basic protein of the eosinophil granules, which I have no way to understand how to interpret this as being positive. But it's very anecdotal in terms of what is going on. But I think my understanding of the literature so far is that almost all of these cases of renal involvement have seen eosinophils actually in the tissue to kind of connect with the peripheral eosinophilia. So what might have gone on with this patient? I think she definitely met criteria for hypereosinophilic syndrome. If you look at the absolute eosinophil counts in the outside hospital, it might have been even higher. So this is a scale of 6 over here, the normal reference range down here. So when she came into the UW, I think she was started on solumedrol, and I was able to suppress her peripheral eosinophilia that still remained kind of elevated above the reference range. And of course, we had no visibility what was going on in the bone marrow during this entire time. Now, during this entire course, and even probably prior to admission, she probably had a TMA, like symptomatology, which was affecting the kidney and other organs as well over time, possibly related to her altered mental status as well. You can see, though, however, in the last few days of her life, the D dimer starts to creep up, LDH spikes, and of course, the platelets were chronically low throughout this entire time. So I think, during her entire hospital course until the last couple of days, she was really developing a TMA-like presentation, which has been associated with hypereosinophilic syndrome, presumably due to release of the granule components, major basic protein, the tryptase, and tissue factor from eosinophils that could stimulate a TMA. Now, the contradicting data, of course, is that the tryptase level that was measured once or twice was normal. But this may have been in the context of kind of a normalized peripheral blood eosinophilia. Again, we don't have visibility into what was happening in the bone marrow. But eventually, for one reason or the other, maybe because of the pancreatitis, maybe of the pneumonia, she kind of switched into a more DIC-like picture in the last couple of days, and that's when there was a precipitous decline, and she passed away. So, kind of the questions are, whether earlier and more aggressive treatment with steroids would have benefited this patient. I think it was a diagnostic challenge very early on, even in the outside hospital, and there was a really extensive workup that was done to evaluate all the known triggers of hypereosinophilic syndrome. We don't know if there was a complement-mediated component that was genetically driven in this patient, so that's also another possibility. Clearly, there was TMA, and the question is whether the eosinophilia was driving the TMA. Some reports have also described using imatinib and some of these other agents as well to try to suppress eosinophil function and degranulation. And so really speculative as to whether any of these would have made a difference in this case, which was really very precipitous and aggressive, and unfortunately had a poor outcome at the very end. So I'll stop there, and we can entertain any questions which we may not know the answers to. So,
what about plasmapheresis?
So I think she was undergoing plasmapheresis, when there was the presumed ADAM TS13 and TTP. So I don't know how that correlates with the clinical improvement. But it was also the time when she was on solumedrol, and that suppressed her peripheral eosinophilia. So it's like, which one was actually benefiting her at that temporary period?
Yeah, patient had 3 episodes of plaques, and we did have a conversation during professor rounds, and Dr. Kim Muzinski said maybe we should continue plaques at that time, because even though we don't know the mechanism, but it seems the patient's eosinophils got controlled when the patient was on plaques.
Yeah, other questions? All right.
Yeah, I guess it's just a question of, had she survived, what treatment we would have done, if we would have restarted plaques after that, or just continue the steroids.
Yeah, I wonder if more intense suppression of a bone marrow was needed. I don't know what that would look like long term. The literature is kind of all over the place. Some patients have survived, many patients have survived, others have not survived. Based on how she presented and progressed during her hospital course. She seems to have had a very aggressive form of this disease. And you wonder, even the earlier episodes of urticaria, and late last year were really kind of the beginnings of this whole process. We don't know what the trigger was.
Yeah, we had a discussion. I had a discussion with Ram yesterday, so we think we agree. So maybe at that time, maybe we should increase the dose or continue the pulse dose of steroid for that HES treatment. But at the same time, it's hard to balance the immunosuppression and followed by the patient has aspiration pneumonia, septic shock. So it's hard to balance the infection and the immunosuppression at this time.
Okay, so in the interest of time, we'll maybe stop here and then move on to Behzad's case.
Okay, thank you, Ram. Very interesting and definitely complicated and unfortunate case. Okay, so let me share my screen. Let's see. All right. Does it look right, everyone?
Yes, that's better.
Okay, all right. Okay, so let's move on. And the clinical part of this case will be presented by Dr. Sarah Hager. Sarah?
Hi, yeah, thanks so much. So this case is of a 71-year-old gentleman that has a history of hypertension and then recently diagnosed Bell's palsy, who presented to the emergency department with 10 days of lower extremity and facial edema, dyspnea, and fatigued. He's prescribed lisinopril 10 milligrams daily for hypertension, which he's no longer taking, and then gabapentin for neuropathy. He denied any NSAID use or any other over-the-counter medications or supplements. In the emergency department, the following was obtained. So on physical exam, he was afebrile, his heart rate was 74, he was hypertensive with his blood pressure was 144/95, but was oxygenating well on room air. He did have prominent periorbital edema and then 1 to 2 plus bilateral lower extremity edema. He didn't have any rash and his lungs were clear. These were the labs that were initially obtained by the emergency department. So his CBC was relatively normal except for a thrombocytosis with a platelet count of 507. His BUN was elevated at 36 and creatinine elevated at 2.17 from a baseline of 1 to 1.2. His creatinine was last at baseline about a month prior to this. In the emergency department, a UA was obtained first, which showed 4 plus protein, 3 plus blood, no white blood cells, 3 to 5 red blood cells, 6 to 10 hyaline casts, and then granular casts. And then because of this, urine protein and urine albumin creatinine ratios were obtained, showing 15.6 grams of proteinuria and 9 grams of albuminuria. His serum albumin was 1.8. And then just getting further history and review of systems from the patient in the emergency department, he stated that he was diagnosed with syphilis about 2 weeks prior to presentation. He was treated with 1 dose of intramuscular ceftriaxone and then didn't want any additional injections, and so was started on oral doxycycline for latent syphilis of unknown duration. 2 days after starting doxycycline, he developed edema and shortness of breath. He came back to the emergency department at that time. They stopped his doxycycline and he was treated for a possible allergic reaction. In chatting with the patient, he thinks he contracted syphilis with a new partner that he's been sexually active with for about the last 4 months. And then otherwise review systems were just pertinent for a facial droop that he had with his newly diagnosed Bell's palsy that was thought to be due to syphilis, but had no rash, genital lesion, vision changes, gait impairment, or any other symptoms. And then some additional labs were obtained before a kidney biopsy was performed. And so this revealed an isolated low C4. His rheumatoid factor was less than 10 and his complements were negative. He tested negative for HIV, hepatitis B. He did have a hepatitis C antibody that was positive, but PCR was negative. And then he tested negative for ANA, ANCAs, and anti-GBM. His anti-PLA2R was negative. And then he had elevated both kappa and lambda light chains, and the ratio is a little bit higher than the upper limit of normal. And he had a normal A1C. And at this time, a kidney biopsy was performed.
Yeah, thanks, Sarah. So questions for Sarah? And then these are the list of my questions for you. Do check mark, the check marks in front of any of those that you think we're going to see in the biopsy. Infection-related glomerulonephritis, membranous nephropathies becoming more popular. Okay, so more people think that it could be membranous. That's good. All right. Okay, so sounds like membranous is very popular, and then also we have infection-related glomerulonephritis as well. So let's see what the biopsy showed. So this is the low magnification, and as you can see, a really good sample from cortex. And we had about 20 glomeruli. All of the glomeruli, they were patent. Look at the biopsy core, really not much. So this is Jones methylamine silver, right? We're not seeing much black. So there's, in these areas, a little bit tubules are separated. Looks like also we have these blue or black dots, so maybe there is inflammation in these regions. In the other regions, not much chronic injury. And when we're looking at these glomeruli, none of them, they look like globally sclerotic glomeruli. So not much chronic injury. That's good. So this is one of the glomeruli, and great majority of them look similar. The question is that, is this normal? Is this abnormal? And you can say whichever of those that you want. It's one of those cases that when you look at the glomerulus, it doesn't quite look right, but it's not very, doesn't have very obvious abnormality. So looking at them, if I want to tell something about this, I would say that, okay, I mean, the glomerular basement, this is Jones methylamine silver, so I'm expecting the glomerular basement membranes to stain well, but there is some variability. I'm seeing more eosinophilic material in these areas. Mesangial areas are not really expanded. I see a few leukocytes hanging around in the capillary lumina. Maybe some of them are neutrophils, but that's really all. We didn't have any crescents. We didn't have any necrosis. We didn't have any endocapillary hypercellularity. There's maybe slightly eosinophilic material, as I said. In some areas, you feel more than normal, but definitely, many people said membranous nephropathy, no obvious holes in the GBM, no obvious spikes, none of those. And looking at the rest of the renal parenchyma, as you can see, this is one of the proximal tubules that partially you see that the tubular epithelial cells are flattened, have lost their brush border. So definitely there is an element of acute tubular injury. Look at here, I mean, right in the middle of our picture, you see a mitotic figure. So we have some reactive changes in the tubular epithelial cells. Some acute tubular injury is going on as well, but not much chronic injury. A view from the PAS, looking at the glomeruli again, not the prettiest glomeruli that you could wish for, but not much abnormalities either. I mean, maybe at most, by looking at this, one could say that maybe glomerular basement membranes are a little bit thickened, maybe not. We'll do electron microscopy for that. And the brush borders are shortened, or in some areas they are lost. Not terrible acute tubular injury from morphologic point of view. In some areas of the cortex that you saw low magnification as well, the tubules are separate. So we have some expansion of the interstitium. In those areas, we have a mixture of edema, inflammatory cells. Some you could recognize as plasma cells, some of them as lymphocytes, maybe very rare eosinophils, nothing like eosinophilic aggregate. No granulomas at all. And these areas of inflammation were pretty limited, not widespread at all, as you saw on low magnification as well. This is another glomerulus at the higher magnification. Again, you can get the kind of similar intuition that is what I mentioned. You see kind of like, it looks like we have some eosinophilic material, but on Jones stain, cells cytoplasm are also eosinophilic, so sometimes we have the widening of food processes, also they lead to eosinophilic material looking on the glomerular basement membrane, but definitely not quite normal, not quite normal. And also rarely we had these sloughed cells accompanied by maybe a few neutrophils, but nothing that you could call neutrophilic cast, and this was a very rare phenomenon as well. So we have interstitial inflammation. So far by looking at light microscopy, it's not normal. We have acute tubular injury. The glomeruli look a little bit abnormal, but definitely we need more information to be able to classify what we're dealing with. And most of you mentioned about membranous nephropathy, also infection-related glomerulonephritis. So for those, we definitely want to have immunofluorescence. So this is how immunofluorescence microscopy look like. So look at these images well, because after this, I want to ask you a question. So I'm putting IgG, C3, and C1q, which were the positive states. And so this is how the IgG look like. This is how C3, more modest, I would say. And IgG is not the strongest, but I mean, now we have two eras. Prior to fixing our immunofluorescence microscope, everything was a little bit dimmer, and this is during that era. So it could have looked brighter than this if I look at it today. And also we have C1q, which was also modest, but we have some C1q. Remember, C1q is which complement pathway? The classic. So this is the question for you. How do you describe this IF pattern? So put marks in front of any of those that you think is a better match. Peripheral capillary wall, like the membranous nephropathy. Starry sky, which goes with the infection-related glomerulonephritis. Maybe the stains were mesangial. MPGN, you can also see peripheral capillary wall and mesangial, or it looked smudgy. Okay, mesangial, peripheral capillary wall. Okay, so I would, yes, and I agree. I agree that, you know, that the pattern is mostly peripheral capillary wall. If you follow these, you see that, yes, I mean, sometimes when the stain is over the mesangial areas, it becomes difficult to tell whether that's under the basement membrane or above the basement membrane. But you follow, and if you can continue up to the end where the capillary lumina are, and still you see the stains on top of those, that means that you have peripheral capillary wall stain. And that mostly looks like a membranous pattern. So with membranous pattern, the first thing that you want to know is that, okay, is it PLA2R positive or is not PLA2R positive? So we do staining for PLA2R, and it was black negative. So it's categorized as one of those PLA2R negative cases, right? So the next question is that, okay, do we have features of secondary membranous? And you remember that, you know, we were interested to know, excuse me, extraglomerular deposits, for example, and we didn't have those by immunofluorescence. Were there mesangial deposits? We were not convinced by immunofluorescence, but sometimes it's difficult. So now let's look at the electron microscopy. So by electron microscopy, this is kind of like lower magnification still, not very high. And one thing that I'm hoping that you can pick up at this magnification, at least, is that there is extensive food process effacement. So we have a lot of podocyte. That can explain why the patient is so much proteinuria. But there is more information into this. And by the way, I mean, the mesangial regions, as you can see here, they look fine, maybe a little bit expanded, but they don't show deposits. Okay, so, but we see deposits in here. So if you put a few marks on the deposits, that will be great. And to orient everyone, so here, this big guy is the red blood cell, so this is a capillary lumen. We have an endothelial lining. As you can see, I don't see tubular reticular aggregates, glomerular basement membrane, so I don't see any marks on the deposits yet. But this one is a podocyte, and as you can see, the podocyte is showing a lot of food process effacement. The podocyte is covering these subepithelial deposits. Thank you very much. So these subepithelial deposits, as you can see, they have almost no adjacent glomerular basement membrane reaction around them to cause the spikes or holes where we are looking at the Jones methylamine silver. And that was, in fact, a very consistent finding. throughout this biopsy. So again, a closer look, glomerular basement membrane, all these deposits, some of them pretty large, some of them maybe are approaching hump-like appearance, and almost none of them are showing any GBM reaction to those. And another one, this is a kind of tangential cut, and you see a lot of subepithelial deposits, no GBM reaction. Some of them have a very peculiar look. They look kind of like hump-like. Again, no GBM reaction. So, I mean, when we don't see no GBM reaction, I mean, in the earliest stage of the membranous, like stage 1, that's what we say. So maybe, okay, stage 1, but with large subepithelial deposits again, as you can see in these images. What about the tubular interstitium, acute tubular injury? As you can see in this image, the interstitium, a little bit of collagen fibrils, not more than that. No TBM deposits, no interstitial deposits. Okay, so in this particular case, I was interested to do IgG subtyping, even though that there was no bias of kappa versus lambda, but C1q was positive. There was a history of syphilis, so therefore we do IgG subtyping in this case, because if it is, the question is that membranous nephropathy associated with syphilis has some interesting features. And one of the interesting features is that typically IgG4 does not show up. In most cases, IgG1 is the dominant. So we did this thing, and in fact, as you can see, IgG1 was the strongest. We had a little bit of IgG2, we had a little bit of IgG3 weaker, and we had no IgG4. So that feature also meant that. And let me also emphasize that what I described for EM is also typical for membranous nephropathy associated with syphilis. So, and it's pretty consistent from old cases where we didn't know that, what the target antigen is, up to now. All of the cases that you look in the literature, subepithelial deposits, some of them are pretty large, may look like hump even, no GBM reaction. So definitely, I mean, we are looking at like a peculiar, a very peculiar subtype of membranous nephropathy. So this is the final diagnosis. Membranous nephropathy was the initial one that we did. PLA2R negative with features suggestive of potential association with syphilis. We had some acute tubular injury. We had mild and patchy acute tubular nephritis. We did Wharton-Starry stain, by the way, even though the inflammation was very limited, did not find any spirochetes, and also the chronic injury. So putting everything together, PLA2R negative, so secondary, maybe also the no GBM reaction by EM. Some of the deposits were large. It was IgG1 dominant. So putting all of these things together, we thought that this is very likely syphilis associated, and therefore we now know that the target antigen is NDNF, neuron-derived neurotrophic factor. So we sent out the specimen to Mayo, and it was confirmed that it was indeed an NDNF-associated membranous nephropathy. So this is basically the original paper that the Mayo Group published with their 8 cases, and of these 8 cases, actually, I mean, seven of them, they had confirmed syphilis infection, and one of them was HIV positive infection. Syphilis was never tested in that one, and there was one that was had long tumor, and the long tumor, they called it, it's like basically an unusual case. But you have to consider that also when you look at the Human Protein Atlas, indeed, the organ that shows the strongest expression of NDNF is lung. So there might be, I mean, something there as well. Similar to our case, PLA2R negative. In their cases, IgG1 and IgG4 was negative, and also the deposits also pretty similar to our case. As you can see, the deposits are sticking out, are large, and they don't have any GBM reaction. So NDNF, is this expressed in the podocytes or not? Yes. I mean, in fact, the great majority, this is a very, very good paper that was published in Genes very recently. And so in adult kids, most of these membranous nephropathy target antigens are present in the podocyte. That's what they found, except PCSK6 and CAM1. And PLA2R is expressed more than any of the other ones. But definitely we have PLA2R, NTMG1, HTRA1, and NDNF that they have enriched expression in the podocyte. And this is our basically NDNF. And these are the podocytes. This is the cluster for the podocyte that shows enrichment of expression. But I mean, nevertheless, so NDNF is one of the other membranous nephropathy antigens that are primarily neural proteins, including NEL1 and CAM1s, contactin 1, semaphore 3B, and netrin G1. So for the sake of time, I mean, this is a paper that just says that, you know, in limited number of cases that they looked at with syphilis and membranous nephropathy, close to half, a little bit less than that, them were NDNF positive, and also probably equal percentage were PLA2R positive, and you know, 1 or 2 cases were negative for both. Okay, so we have a couple of follow-up slides that Sarah is going to present.
Yeah, so just follow up for this case. On the first day that the patient was admitted, ID was consulted and the patient was started on IV penicillin G for 2 weeks for concern for possible neurosyphilis in the setting of the patient's Bell's palsy. On hospital day 2 is when the biopsy was performed. On hospital day 3, the patient was started on diuretics for edema and dyspnea. Hospital day 4, the patient was diagnosed with the PE and started on anticoagulation for that. On hospital day 7, the patient developed large volume hematuria requiring Foley placement and continuous bladder irrigation. Luckily, the patient was found to be bleeding from the contralateral ureter from the kidney that was biopsied, and there was concern for a possible ureteral neoplasm that was seen on imaging. Because of this, the patient had worsened kidney function due to bladder outlet obstruction from hematuria and blood clots, and so the patient kind of had a prolonged admission following this. They were continued to be admitted for ongoing diuresis and intermittent hematuria. Finally, anticoagulation was restarted prior to discharge, and the patient's creatinine was improving at that time, down to 1.57 at discharge from a peak of 3.9. At follow-up, about like a month and a half later, the patient's creatinine was down to 1.1, and we're currently awaiting repeat quantification of the patient's proteinuria. And so this just left us with a few remaining questions. So first, how long after exposure to syphilis and during what stage of syphilis infection does membranous nephropathy usually present? And so a lot of the cases reported found that this usually doesn't occur earlier than secondary syphilis. And so in our patient, it seems like they had probably been exposed about 4 months prior. So this was consistent with membranous nephropathy due to syphilis. And then the second question that we had is treatment of the syphilis infection alone enough to treat the associated membranous nephropathy, or is additional immunosuppression indicated? In 2 of the reports that Behzad already presented, 100% of the patients with NDNF staining on biopsy developed complete remission with treatment of syphilis alone. And this was with an N of 6 of patients that had positive NDNF biopsies and an N of 5 in the other report. And so hopefully this patient, their creatinine is improving. So we'll see what happens with their proteinuria after they receive treatment of their syphilis.
Thank you. Questions? Comments? So I think that it's, I mean, obviously, I mean, when you treat the syphilis here, you remove the primary cause, and therefore the deposits will be reabsorbed. But I think that also the response could also be due to the fact that, as I showed, consistently in all of these cases, we don't have much GBM remodeling. It's very interesting. So you don't have any, you know, like those spikes in it, because when you alter the structure of the GBM, even though that if the deposits are removed, like in stage 4 of membranous, still you can have proteinuria, or it takes longer for the remodeling to recover.
Hey, Behzad.
Yes.
Do you think, like, at least in theory, like, would there be any potential value for measuring circulating NDNF antibodies in like secondary cases? You know, like kind of the way anti-PLA2R is informative.
Yeah, so I mean, I found only one study that in limited cases, I mean, they in acute they extracted the antibody and they measured the antibody, and they showed that yes, with the treatment, when the disease went into the remission, the antibody titer was reduced. So potentially, I think yes, but I think that these cases are not common to do a large number of studies such as PLA2R. And so the antibodies are measured here, right? Or no? Or anti-NDNF? I don't know. I haven't checked our lab medicine. But hypothetically, yeah, should be helpful.
Yeah, we don't measure the antibodies here.
Okay.
Ashley had another question there in the chat. Why is there limited GBM reaction? This reflects short-term duration and/or acuity?
That's at least part of the story, but we don't know. I mean, in reality, we don't know. I mean, it was kind of striking for me, actually. I mean, when I looked at the prior, even old report of syphilis-associated membranous nephropathy, that in all of them consistently we are seeing this. I think it's a little bit more into that. As I said, it looks like it's an entity of its own. It has very characteristic features that are consistent. So probably there is more into it, and that it will be very interesting to answer that question. It looks to me, but I don't have any firm evidence or hypothesis for that. But it looks to me that there should be more into it than only the acuteness of the process.
Well, it's 9. We're past time now, and so thank you all today for very good talks and interactive sessions here with our colleagues in pathology. And so, just one more reminder for next week, we'll be back in person again at South Lake Union for the special World Kidney Day Nephrology Grand Round session. So, thank you everyone. Hope you have a wonderful weekend. I'll see you all next week.
Thank you.